No, 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 no. That wasn't dramatic enough. The number that you've been here for 11 months. Hey guys. Hi, what's up? How are you?
Code red LL632. Code red LL632.
You have this temperature? How much?
It says off. Hi everybody, I'm going to talk about nutrition. As in the previous slide, it says it's 4% of the board exam. Okay, so we're going to start with dietary requirements. So an average daily dietary intake is necessary for normal growth and development. Uh, we, we need to assure that the patient has adequate energy, protein, minerals, vitamins, and essential fatty acids. So a daily energy needs are composed of basal energy, metabolism, uh, the growth required for the what is needed for the growth requirement, physical activity, fecal losses, and thermic effect of the food. So caloric needs varies depending on the age. We have for a neonate, more or less they need 120, even 140 kilocalories per kg per day. And then we see that for older people and the requirement decreases. And for adolescents, we have a 40 kilocalories per kilogram per day. So growth, we need to make sure if there is inadequate intake. When that happens, we have a decrease in the weight, we have a decrease in the linear growth, and at the end, we have a decrease in the head circumference. So if we have acute malnutrition, we're gonna have weight loss. But if we have chronic malnutrition, then we're gonna have a stunting on the growth chart. So what about breastfeeding? So when you see breastfeeding on your board exam, it's always preferred. You're always gonna say yeah for breastfeeding. Breastfeeding infants should be evaluating within 1 week. You need to assess for hydration status, jaundice, and weight gain. There's risk for jaundice, breastfeeding jaundice. There's risk for dehydration if the mom is not having a good bond with the baby. And also we need to check for weight gain in 1 week and 2 weeks, right? So what are the contraindications for breastfeeding? These are the contraindications. If we know that the patient has galactosemia of a newborn screen, if we know that the mom has active miliary TB with less than 2 weeks therapy, if we know that there's an HIV infection in developed countries, it's different. In undeveloped countries, they just breastfeed regardless of HIV. Yeah?
What about like pulmonary? Like I thought miliary was just like blood from like it's not the air made up to air circulation.
Yes,
I think so.
It is.
So it's because like it's in the nose.
Miliary is in the lungs.
no,
I
because of the
know,
close contact.
It's a close contact, yeah. It's
like
because of the close
it's not
contact.
like pulmonary tuberculosis that it's transmitted via like
Not the milk.
secretion, right?
No,
Yeah,
but if
it's
you have like
respiratory.
miliary tuberculosis, the chances
So
that
that
you
one
have
it's because it's in the
pulmonary.
breast milk. What about like pulmonary TB?
Yeah, the close
If she
contact.
wears a face mask, she's allowed to breastfeed.
It's a close contact.
No, but she needs to be treated.
Yeah,
No,
no,
need to
as
be
long
on
as she's
treatment.
on treatment and she's wearing a mask.
Lesions on the breast. Then we have human T-cell lymphotrophic 1 and 2 virus infection. This one is it's a virus that it's a retrovirus similar to HIV. It's isolated in patients with cutaneous T-cell lymphoma. It's T-cell lymphotrophic 1 and 2 virus infection. And also a specific anti-metabolite therapy, like if the patient is getting chemotherapy or something that is gonna, go through and not gonna affect the baby. Okay. So the question is like formula versus breast milk, right? One of the things about formula is that it's not biologically active, and breast milk is more. Also, the higher amount of protein, calcium, and phosphorus that is found in formula is good. When do you give formula? That's the question that we all have, right? Only when the mother asks for it. If the mother says, I don't want to, I try and I can, and at the end it's her choice, so she can decide on that. Also, you substitute if it's a contraindication like in galactosemia. And you can supplement in breastfed infants that have an inadequate weight gain, like whenever we have patients that are admitted for that reason. So carbohydrates, um, they represent most of the energy in the diet. If not available, then the body metabolizes fat and protein. They are stored as glycogen, and we know that infants have less reserves. We know also that they're the common cause of obesity, and it's excessive heating, and we have hidden calories in high fructose corn syrups. So this one goes with this one. No, it's like this one, and that's for this one. So we know that ketosis happens when the intake is less than 50% of the total calories due to oxidation of fatty acids. Just talking a little bit about fatty acids. Yeah, but you have ketosis, right? When you don't have enough carbohydrates, you go to ketosis, right? So that's what I'm saying. Hmm. Okay, so when child reaches 2, the intake decreases, and we need to assure normal growth, and we need to check for BMI. The problem with the parents is that they don't want to try different things on the baby. They say they're picky, but now we're saying that you need to expose the child 10 times to the food in order for you to fit the food. And then also, I'm going to talk about fats. I don't know why this one is here. Okay, so fats, we see them in cell membranes, precursors of hormones, and are efficient they're usually in efficient energy storage. We have GI disease, and the medium chain triglycerides are helpful, but we still need to provide long chain fatty acids that are essential. Supplement with that. So a little bit about formulas. All formulas available are meeting infant needs per AAP guidelines, except goat's milk, still lacking folic acid. The protein contained is responsible for allergic symptoms we know in the formulas, so you may need to change the protein source. The more hydrolyzed, the less antigenic is the formula. There are also amino acid based formulas. These are better absorbed, but are the least allergenic, but they're more expensive and they smell really bad. So we have cow's milk, so formulas based on cow's milk, soy, hydrolyzed proteins, and amino acids, and then the amino acids have less aller- allergenic reactions. So when would you give soy formula? Well, you give formula when the patients have like lactase intolerance, right? So soy formula is nutritionally adequate for term newborns, but it's not indicated for preterm newborns. It's contraindicated also in enterocolitis. And hydrolyzed formula, hydrolyzed protein formulas are indicated in enterocolitis. It's good to know this. And AA formulas, amino acid formulas are to be used if you have a true severe allergy because of the previous problems, as they're very expensive. So I have a question. A previously healthy 5-month-old presents with acute onset diarrhea. On exam, the patient appears well hydrated. You have seen children with similar presentation all week. The most appropriate therapy is A. Begin a lactose-free formula. B. Begin oral rehydration therapy. C. Continue current breast formula feeds. D. Change to feedings with hypoallergenic therapy. Yeah, so it's like an infectious diarrhea because on the question they say you have seen children with a similar presentation all week, right? So you have to think, oh, that is not something that it's been happening from the beginning. Just it's acute. So you have to continue the current breast formula. Okay, so nutrients. I'm gonna talk a little bit about this too. We need to have a fiber. A daily intake is zero point 0.5 grams per kg for 24 hours. And if we have decreased fiber, we know that it's associated with constipation. It could also be associated with appendicitis and diverticulitis. We also have to keep in mind that we need fluoride and we have to supplement fluoride. It's recommended for infants more than 6 months if the water supply contains less than 3 parts per minute. So that's 3 ppm. I don't know what is million.
Parts per million.
Per million. Parts per million. Per million. Million.
Million.
Million. So I don't know what it meant. Sorry. So less than 3 ppm, then you are going to have to supplement. You also have to be careful because you can have fluorosis. It could affect the teeth of the babies. So you have to give a small amount on the toothpaste whenever you give the recommendations. You make sure that it's a little amount. Okay, so let me talk about iron deficiency anemia. After 5 months, there could be permanent neurodevelopmental effects. So now we know that. We need to know that fortified breast milk are less expensive and that um, less expensive as formula, right? Formula has iron. So yeah, low birth weight newborns are at greater risk. Hmm? Anemia in 1980s, and this was due to an increase in breast feeding and the use of iron fortified formulas, right? So even though breast milk has a small amount of iron and it's good if the baby's term, the use of iron fortified formulas help with this decreasing the prevalence of iron deficiency anemia in 1980s. You understand that? So 1980, there was a study done for IDA, okay, and there was a decrease in the prevalence of IDA, and they thought that this was due to breastfeeding and the use of iron fortified formulas. So IDA manifestations, so we're gonna have behavioral changes, poor growth, decreased exercise tolerance, we can have anorexia, pica, we can have changes in stool color, we can have red urine, breath holding spells. I thought that was kind of different. We don't usually see breath holding spells, but that could be asked on the board. You have to prescribe iron fortified formulas, and you have to supplement premature newborns, as we said. You have to supplement breastfed infants if exclusively breastfed beyond 6 months of age. Term infants. Okay? So let's talk about deficiencies. So we can have deficiencies that are caloric, or we can have deficiencies in protein. Marasmo is a caloric malnutrition. Kwashiorkor is a protein malnutrition, and we can also have it as mixed protein and caloric malnutrition. So in marasmus, the problem is that you're not going to have muscle mass. The patient's going to look wasted. What shorters, you're going to have more like an edema, spontaneous edema. And then the mix will have, the patient will be wasted with spontaneous edema. So fat soluble deficiencies, or ADK, We've seen them in short bowel when there is less absorption due to the decreased surface area. The fat digestion requires two things: bile salts, and we also need pancreatic enzymes. So you need to have your liver and your pancreas working in order to absorb them. We have vitamin A deficiency. Vitamin A deficiency
Code
is
red, all clear. Code red, all clear.
There was a question that there was an association with taking blood like different modalities is vitamin that associated with vitamin
nice.
Lactate syndrome.
There's a grab question.
Yeah, about difficult for deficiency.
Yeah. Okay, so vitamin A deficiency is still a worldwide problem. Um, we see vitamin A in beta carotene vegetables like carrots are the major dietary source. We will have eye and skin problems like xerophthalmia, impaired night vision. We can have perifollicular hyperkeratosis. We are at risk of fat. We are at risk if we have any fat malabsorption or if the liver content is low at delivery. The breast milk content is adequate for vitamin A. In the third world countries, is the most common cause of blindness. Currently, they are working on a vitamin-rich rice. It's called the golden rice, and it's a supplementation program. I thought it was good. So vitamin A toxicity, we can have acute or chronic. We need to know that it's teratogenic in early pregnancy. The cause is often iatrogenic. You can have acute onset of nausea, meaning that you take too much vitamin A. That's what I attribute. Acute onset of nausea, vomiting, headache, vertigo, and blurred vision. And chronically, you're going to see ataxia, alopecia, it's hepatotoxic. You can have tumor cerebri, bone, and muscle. So vitamin D deficiency, we have rickets. We know about growing child that's restless, has poor sleep, kinetics, developmental delay too. Can have the rachitic rosary, the increased space in between the wrist, the thick wrist, the bow legs, right? And then we have osteomalacia, is in older patients, bone tenderness, and they have muscle weakness. So the deficiency is widespread. We have 25 hydroxy D, vitamin D, is less than 32, is the best indicator of vitamin D body store. And we can also see increased alkaline phosphatase, low phosphorus, and increased PTH. Like they will put that table with these things. So you need to know what is increased in rickets. Yeah, yeah, low calcium and low phosphorus. So breastfed baby at risk after 6 months. They are at risk after that. And they will have dark pigmented skin. They will have a history of decreased sun exposure, living in the northern areas. Then you think this could be the reason. Okay. Also, we need to know that breast milk has low amount of vitamin D, so it needs to be supplemented. Vitamin D metabolism includes sunshine, then it goes to skin, intestine, liver, and kidney. Okay. And the recommended calcium and vitamin D intakes are, I didn't put the whole table, but I talk about 0 to 6 months so you have an idea. You need 200 milligrams per day of calcium. Yeah, per day. And 400 international units per day of vitamin D. From 1 to 3 years, and in your source of calcium increases, you need to have 700 milligrams per day, and then 600 international units of vitamin D. Sorry about the typos. So vitamin D toxicity, you can have anorexia, nausea, vomiting, constipation, weakness, polyuria, polydipsia. You can have renal stones. And also you can have increased epiphyseal bone density. Vitamin D is a hormone. And all breastfed babies should receive 400 IU vitamin D from birth until they consume 500 ml per day of fortified formula milk. So that's also another important pearl. Okay, vitamin E. Vitamin E is seen in steatorrhea, liver disease. We're gonna have problems with spinocerebellar tract ataxia. We can have abeta lipopropeinemia. What happens? Vitamin is an oxidant, antioxidant, and there's an imbalance in it, and this will cause also hemolysis. Symptoms will be progressive ataxia, myopathy, retinopathy. We can have axonal degeneration of the posterior column lesions. Um, we can have loss of deep tendon reflexes. And then the last one of the lipid solubles is vitamin K. We know that its primary function is clotting. We need to suspect a vitamin K deficiency when the baby was born at home, and he didn't have no supplementation and is bleeding. Also, we can think of it on a scenarios where like some type of liver disease or some type of malabsorption. We need to remember that vitamin but the factor 7 is vitamin K dependent. So we can measure PT just to make sure that is the bleeding is due to vitamin K deficiency. Okay, so what are the water soluble vitamin deficiencies? So I put the table because it is going to take too long to go one by one, right? So we have thiamine, vitamin B1. Deficiency will give you beriberi, paresthesias, foot or wrist rub. You can also have the CNS bar, which is Wernicke encephalopathy. You can have ophthalmoplegia, ataxia, confusion. Then we have riboflavin, is vitamin B2 deficiency. And you can have cheilosis, sore tongue, oculo-orogenital syndrome. That's how they call it. Niacin, B3. Uh-huh. Deficiency will cause pellagra, the four Ds, right? Dermatitis, dementia, diarrhea, and death. You can also have flushing and pruritus, just in the asking the question. And then we have pyridoxine, B6. You can have seizures with that one. Cobalamin, vitamin B12 deficiency. You have megaloblastic anemia. Folate, megaloblastic anemia, and vitamin C will cause scurvy. Um, it, I'm sorry for the typo. It is destroyed by heating. So if you heat something that has vitamin C, it's not gonna have vitamin C anymore, basically. Like anything that says extra vitamin C in there, and then you warm it up, it's gonna go away. So vitamin warm your oranges. No, I'm joking. Vitamin B12 derived from food mainly, and we know like animal sources. We could have deficiency of vitamin B12 if we have vegetarian diets. We know that vitamin B12 is absorbed in the distal ileum. So labs will show low serum vitamin B12 and increased urinary methylmalonic acid for testing. So that's important to know. So if you want to make sure it's vitamin B12, you can do a urine for methylmalonic acid, okay? And it should be low. Okay, so the same thing. When are you at risk? If you have a diet that is very restrictive, and you will be deficient in vitamin B12, iron, zinc, and calcium. So what do we see here?
What is the condition?
What is the condition? Huh? What is the name of it? Good job. So yeah, it's acute recessive inheritance is acrodermatitis enteropathica due to malabsorption of zinc through the intestinal cells. It's associated with these mutations in this gene. that causes zinc transporter protein. Okay. Also, we need to know for exam that long-term parenteral nutrition, TPN, and a rash, we need to think of the most common causes will be zinc deficiency, essential fatty acids deficiency, or biotin deficiency. Okay. Talking a little bit about obesity. I know Endocrino is going to talk more about it, so I'm just going to talk a little bit about it. Uh, Metabolic syndrome. We know that is when you have a BMI that is bigger than 85, plus two of the following: triglycerides more than 150, HDL below 40. I don't know what happened there, typo. Uh, and BP, blood pressure more than 85th percentile with insulin resistant signs. Okay, so that's what it is. And you know that when you have obesity, you're gonna have obstructive sleep apnea. You can have complications with SCFE. You can have gallbladder disease and non-alcoholic liver disease, the most common liver disease today. You can have polycystic ovarian syndrome, and of course, you can have cardiovascular disease. So this is a major problem right now with our teenagers. So, mhm, mhm.
Cardiovascular disease.
Cardiovascular disease. Most common liver disease today, sorry.
Oh,
I'm sorry. Okay, so what can we do to prevent obesity right now? Um, the AP suggests this 5210 plan. When you have 5 servings per day, like 3 meals, 2 snacks, fruits and vegetables to be substitute from like carbohydrates and sugar-rich products. And you have to reduce the screen time, maximum 2 hours per day. And you need to tell them that they have to have 1 hour physical activity per day and no sugar sweetened beverage added. They also like to ask this about water soluble vitamins deficiency in utero. So if we have if we have vitamin B12 deficiency from the mom, the mom that is vegetarian, the baby could have neural tooth defects. Also, folate deficiency is associated with risk for spina bifida. Vitamin C is needed for collagen and affects vessels and bone junctions, so the baby could come like to have problems like losing teeth, bleeding gums, painful brittle bones. Okay, there's another one question. Somebody wants to read? Yeah. So why is it vitamin E?
It's also like hemoglobin and swallowing very fast, so it's associated with
So yeah, it cannot be thiamine, which is the only non-lipid soluble, water soluble vitamin, and the C cannot be. So it's only A and E, and A cannot be because it's nothing like related to that. But we need to know that vitamin E is fat soluble and requires fat for absorption. So the testing was removed, so less surface area for absorption. And also we need to remember that vitamin E is important for myelin formation. So you can see long nerve signs, okay, like what we have here, the limited ability to look upward. So if you see something like that, deep tendon reflexes, are decreased, like in the knee reflexes, then you have to think of vitamin E deficiency.